My name is Tanya Wiese. I'm a physician. I practice interventional pulmonology at the University of Louisville. And today we're going to be talking a little bit about bronchial thermoplasty and how it's used in severe asthmatics. And we have two individuals who actually suffer from asthma and underwent bronchial thermoplasty that are going to share their experiences today with you. So what I'd like to do is briefly go over asthma, in particular severe asthma, just so we're all on the same page, as this treatment is approved only at this time for severe asthmatics. We're going to talk about bronchial thermoplasty with the Alair system, which is the only system on the market right now for this therapy. I'm going to review briefly some of the clinical data, the patient selection criteria. So just a little bit of an overview. This is data from 2009. Newer data hasn't been released yet, but if things are trending the way they've been trending, asthma is on the rise. So these numbers are probably higher than they are from 2009. Over 24 million people suffer from asthma in the world. Of these patients, about 12 million every year experience a severe asthmatic attack. About 2 million visit the emergency room for their asthma. And about half a million people every year are hospitalized with asthma. And then if you look at the statistics and break them down, every day approximately 9 people are dying from asthma. So I think it's interesting. The last statistics I saw on this were probably 11 people a day now, which if you think about it, I think there are a lot of people out there in the community who still think of asthma as a disease that is not one that would cause death. So this is, you guys are probably familiar with the little pyramid of how we treat asthma. For mild asthmatics, we usually start off with a short-acting beta agonist and inhaled corticosteroid, and we work our way up. When we start getting up to 5 and 6 level, where we start considering other things like Singulair and Xolair, these are the patients that we need to target different ways to treat them because most things don't work for them. And then the things that do work for them tend to have a lot of side effects. The first thing I'd like to talk about is the mimickers of asthma, because we do have a lot of asthmatics that may appear to have severe asthma, but actually maybe only have mild asthma, and it's being exacerbated by something else. I think the most common in the United States right now is esophageal reflux due to our diet and our weight. A few of the other things you might pick up in some of these patients are vocal cord dysfunction, CHF, postnasal drip, or pulmonary hypertension, and then occasionally something in the airway. So tracheal stenosis, a foreign body, or a hamartoma, which is one of the most common benign tumors. So there may be other things. So one of the important things is you want to identify somebody with severe asthma first, rule out other things. If you look at some of the statistics, most of the societies out there say that of all asthmatics, about 10% of them are severe asthmatics. So if you go back to the numbers on my first slide, that's a lot of people with severe asthma that need help that we're not right now currently providing them. And then even despite the therapies we're giving them now with Xolair injections, oral steroids, they're still having symptoms, still ending up in the hospital. A lot of these patients may not have adequate access to health care or insurance for medications, so they may be another population that use a lot of resources unnecessarily. If you look at the total cost, and this is just for the United States, or this is actually worldwide, that we spent on asthma, that's days lost, hospitalization, ER visits, medications, it's over $20 billion. So a serious healthcare problem. So this is just a little schematic of what the smooth airway muscles look like in the airway. So this is your airway cut on end, and you can see in a normal patient over here, the smooth airway muscle is pretty thin. The airway is a lot like any other muscle. You know, you work it enough, it's going to become hypertrophied, and that's what happens in asthmatics. They're constantly constricting and dilating, constricting and dilating, and so the muscle becomes hypertrophied, which obviously narrows the airway even more. So now they have asthma and they have narrow airways from this hypertrophied smooth airway muscle, which makes it difficult. And then if they have a trigger, it's much easier to have a severe attack with this constricted airway. So what does bronchial thermoplasty do? Its aim is to reduce that hypertrophied smooth airway muscle and then opening up the airway more, and it also doesn't allow the airway to constrict as much. And I have a little video clip I'm going to show you on that. And then you obviously reduce the exacerbations and improve quality of life. So what it is basically it's a therapy where we take a catheter and we deliver it into the inside of the airways, and we heat up the airways. Heating up the airways then allows the muscle to reduce, and then it doesn't allow it to constrict as much to the environmental allergens or intrinsic asthma. We do ours in our hospital under general sedation. We do it in 3 separate sessions because the most common side effect to the procedure is an exacerbation of their asthma. So we break it up. We'll do part of the lung, wait 3 weeks, do another third of the lung, wait 3 weeks, and do another third of the lung. And then we pre-medicate the patients before and after with steroids. One of the first things I tell my patients is that this is not a cure for asthma. It's just a treatment that will hopefully take you to a more mild, manageable form of asthma. With the studies that are out, their goal was to show improved quality of life, which they did, but there's also been, and we'll go over the data a little bit, some other improvements shown. So this is what it looks like here on my left, your left. It's just a little catheter that goes through the bronchoscope. When you open it up, you have these little metal arrays that touch the airway, and where it touches from here to here is about 5 millimeters. So we go down as far as we can see, we activate it, it takes about 10 seconds to heat up the airway, and then we pull it back every 5 millimeters. And we do that to every section of the lung that we can get to. So this is just a little video clip of what it looks like, a little cartoon. Take the bronchoscope, we're going to go down. You only need a 2 millimeter working channel, so a regular scope, in fact, a regular scope's probably better than the therapeutic scope because you can get down further. Once you get as far as you can wedge the scope in, then you deploy the catheter, push the catheter out as far as you can see, and then you just hit a foot pedal, and you can hear it go off, and it heats it to about the temperature of a warm cup of water or a warm cup of tea, 149 degrees, for 10 seconds. Activates it. You can't actually see anything, so there's no burning, there's no smoke, doesn't really leave any visible signs. Sometimes you might see a little blanching, and then you just move it back. Pretty easy procedure, sort of boring, but easy, at least for the physician. I don't know about the patient. They'll talk to you a little bit about that. So this is actually a live model, so you can see what it looks like. So we're just going out as far as we can. And you see the little black marks there, so we know where we're at. We activate. Once it's done, you'll hear a little beeping noise. But then you pull it back and you keep doing that. And then this is what it looks like. So this was done in a dog model. You can see on the left there the hypertrophied smooth airway muscle. There we go, right in here. And then over here afterwards. And then they actually did a study on humans where they knew that the patients were going to have their lungs cut out. Most of them were for lung cancer. And they didn't even have asthma. They had, obviously, most of them had COPD. But even in those patients, they had about a 50% reduction in the hypertrophied smooth airway muscle. So this is another canine model where they treated one of the bronchial airways and not the other one, and then they injected the patient, or the dog, with methacholine, and you can see what happens. So this is the treated airway, and this is the untreated airway. And they're going to go in, they're going to put methacholine in there, and then you can see how the one that was treated doesn't constrict like the one that did not get treated. So it's pretty impressive. So what does the data show? I'm not going to bore you with too much of this, but basically they started off with their studies very small in mild asthmatics and worked their way up to severe asthmatics to the pivotal trial where they had 190 patients enrolled, and they actually, it was a sham trial, so they actually subjected both patients to bronchoscopy. They put the catheter out in both patients, but in some of the patients, they actually got the heat, and other patients, they didn't get the heat. And then the follow-up that they had were with doctors who were also blinded, who actually got it and who didn't. So it was a very good study. And their endpoint was looking at the quality of life score. So the way they designed it was a 2-to-1 trial. So 2 people received, this is very simple, received the bronchial thermoplasty for every one that got the sham. And then they followed them out, and they just are releasing their 5-year data. And what that showed was that 79% of the BT patients improved their quality of life score by 0.5, which, if you're not familiar with the quality of life score, it doesn't sound like a lot, but it is a lot. It's a scale of 1 to 7. So 0.5 is a pretty significant improvement. And they decreased their exacerbations by 32%, 84% reduction in ER visits, and I think what's important for most of you guys, 73% reduction in hospitalizations for respiratory symptoms. So I know most of you guys here are probably nurses. I was just wondering, a show of hands from you guys, like how many of you guys work in the hospital? Well, not as many as I thought. How about for like healthcare providers, insurance companies? So more of you, okay, all right, that's interesting. Any government workers? Few, okay. So I think that, you know, seeing these numbers is very important. You know, when you can reduce somebody's hospitalization by 73% is pretty impressive, especially when you go back to that number where I showed you that we spend over $20 billion every year on asthma. 66% days lost from work or school, and there were no unanticipated device-related adverse effects or death. So it's a high safety profile, so a lot of benefit for very little risk. So this is the same thing I just went over, but in the graph form. You can see the sham compared to the bronchial thermoplasty patients and the decrease that you have. It's very impressive, especially the ER visits and the hospitalizations. And this is showing the data that it does, you know, people ask me all the time, how long does it last? And they have data now that they're going to be releasing that shows that this lasts out 5 years. And probably longer, we don't know, we don't have the data for even longer. So the side effects, most of the side effects are going to be an exacerbation of their asthma. And usually that happens within the first few days. So if we go to the next slide here, you can see that if you compare the BT group to the sham group, it was a 3.4% compared to 0.7 for events per bronchoscopy, 10% to 2% events per subject. But if you look and you separate out when they had these events, most of them had them on the first day. And thus is why we pre-medicate them with steroids before the procedure. So everything else you could see was pretty low. I've not experienced actually any side effects with any of my patients except for the exacerbations. So to date, there's been no deaths related to it, and the pulmonary function has been stable out 5 years. They also followed CT scans, because if you think about it, if you tell a bunch of doctors you're going to be heating up the airway, the first thing we think about is it's going to be like electrocautery, or you're in there and you're, you know, really burning the tissue and stuff. It's not at all like that. But they wanted to show that there was no structural damage done by heating up the airways, and they followed CAT scans a year out after having the procedure with no changes. So who do you pick? Who gets selected? Right now it's approved for adults only. And it's only being used for severe asthmatics. So what's your definition of severe asthmatic? You know, as a society of medical professionals, we can't even decide on what our definition of severe asthmatic or an asthma for that matter. So a lot of people have their own definitions. You can't really define asthma without the clinical picture. But for the purposes of this study, the study they did, they made it very easy. Anybody who is on long-acting beta agonist and inhaled corticosteroids, high dose, and we're still having symptoms. So that's a severe asthmatic. You don't need to wait until they're hospitalized and going on the vent like some of these people who are going to be speaking to you today, or wait until they're, you know, approved or not approved for Xolair. If they're already on the maximum dose inhaled therapy, then they would qualify for this procedure. Some of the contraindications actually are pretty few, and we don't see this in some of our patient population, mainly because they're usually a younger patient population. But pacemakers, anything that the electric artery is the thermoplasty is going to interfere with. And then any medications to sedation. Some people do this under conscious sedation. I do all my patients under general sedation just because they're not moving. And the most important part of the procedure, even though it's an easy procedure, is you don't want to miss spots and you don't want to overlap spots. So you don't want the patient moving around and coughing, which most asthmatics are going to do if you have a scope down them. And it's a one-time treatment. We're not retreating patients at this time, simply for the fact that people's results have lasted. So, how do you guys play a role in this? I mean, most of you guys are case managers, either in the hospital or some of you with the insurance companies. I think, as a case manager, part of your guys' job is, being a patient advocate, being a hospital advocate. So you're looking out for the patient's best interest, and you're also looking out for society's best interest and what is best for us as a healthcare provider to decrease costs too. So, you want to look for people who are taking their medications and despite that are still ending up in your ERs and in your hospitals, or still on chronic steroids, or looking for other alternatives. There's a website where you can go to look for physicians in your area that may provide the therapy, and also for patients to be educated about what it is and if they qualify. I think a good opportunity too for those of you who actually work in the hospital. I know with our case managers or in our hospital, we have morning rounds. They're always included. What can we do to make sure this time when they go home they don't come back? And in the ERs, we've been trying to encourage them to give little sheets, when you come into the ER for anything, a stitch or antibiotics, they give you a little printout to have the same thing in there. You're suffering from severe asthma, you may want to look into this new treatment. And, putting in a word in there about decreasing your hospital admissions or your ER visits, I think can make a big impact. This is just going over a little bit more about how we do it. This is our little map. We do it in 3 different sessions. I don't want to bore you with that too much. Again, if the patients ask you, well, what is it like? Do you think I could make it through it? They're going to talk to you a little bit more about that. But we do separate them out. That's why it's three separate procedures, to give them time to heal after each procedure and to recover. I pre-medicate my patients 3 days before, and that's what's recommended. That's what they did in the study with steroids. We put them on 50 a day. During their procedure, I actually give them an IV dose because they're under general sedation, and then they take a dose the next day, and that may need to be extended. As I said before, most of these patients are going to have an exacerbation of the asthma. They have severe asthma already, so most of them know how to manage that anyways. They know to increase their nebs or to stay on their steroids. So sometimes they'll be getting the steroids and wean them slowly. Some of them are on chronic steroids, so they were on steroids before they began this, and so you may just be tapering them down to their baseline. And then we always monitor their lung function before the procedure and then after, before we let them get discharged. Most of my patients spend about 4 hours in the hospital after each procedure monitoring them to make sure it's safe for them to go home. So reimbursement, I think this is a little bit state variable. There are some states that are easier than others. I practice right now in Louisville, and it's on a case-by-case basis. Some insurances are much easier. You submit the forms and the paperwork explaining why this patient needs it, and it's not too much of a battle. Some of them, it's a battle. You got to have the patients call, or you have to personally call them. But I think if you're persistent and you show that this person is really going to benefit from this, and they do in fact have asthma that's severe and that's causing a lot of problems in their life, it's not too much of an issue. I just wanted to briefly go over one of my patients I just recently completed, who is a 36-year-old female. She was a teacher at one of the local schools, who was very active. She was one of the swim coaches herself. She was a runner, performed on several marathons, and over the last several years her asthma had been quickly deteriorating to the point where she was pretty much living in the hospital. In the last year, she was in 8 times over a 4-month time period, and the last time she spent 2 weeks on a BiPAP, which is a non-invasive ventilator. She was on high-dose steroids. not, on the verge of losing her job. She was so bad that I wasn't going to do her because she was so sick, and she's like, well, you either do me now or you do me when I'm on the ventilator. So we went ahead and did her. She was following all the standard treatments for asthma, oral steroids, all her inhalers. She didn't qualify for Xolair. She was on Singulair. She was on her allergy medicines, taking allergy shots. We completed her therapy, and 4 weeks after we completed her therapy, she ran a mini marathon and placed 9th in her age group. Since that time, she's run 2 more mini marathons, and she's now training for the triathlon.